Hello, everyone, and a warm welcome to today's edition of Patcast. And we wish you a happy new year. And this is the first lecture of the new year. And today we are starting off with a bone and soft tissue lecture series. And this would be the first lecture in this series. And we would like to thank Dr. Nooshin Dashti for organizing this series of lectures on bone and soft tissue pathology. So for the first lecture today, we have with us Dr. Nooshin Dashti, who is clinical instructor at Cedars Sinai Medical Center, Los Angeles in California. And the title of her talk today would be Rhabdomyosarcoma, Practical Approach, Current Classification, and Novel Molecular Findings. And thank you, Dr. Dashti, for joining us today. Over to you now. Thank you.
Thank you, Rafa, for a kind introduction, and thank you, everyone, and welcome to Bone and Soft Tissue series of Pathcast. Okay. As mentioned, today we're going to talk about rhabdomyosarcomas, their practical approach, current classification, and novel molecular findings in rhabdomyosarcomas. I don't have anything to disclose. Rhabdomyosarcomas are heterogeneous group of tumors. They're the most common soft tissue sarcomas in children and adolescents, accounting to 40% of pediatric soft tissue sarcomas. They are far less common in adult population, less than 5% of sarcomas in adults. They're high-grade malignancies. They're clinically and biologically diverse. All of them show varying degrees of skeletal muscle differentiation, but it could be very, very focal. This skeletal muscle differentiation is usually evident by immunoreactivity for myogenic and MyoD1, two immunostains usually used for rhabdomyosarcoma diagnosis. But while the mainstay of diagnosis is morphology, the distinction between the subtypes can be challenging, especially if we're dealing with the smaller biopsies, and especially if other differential includes tumors that have some rhabdomyoblastic differentiation, such as carcinosarcoma, malignant peripheral nerve sheath tumor, biphenotypic nasal sarcoma, and Wilms tumor. Currently, the most recent edition of WHO classification of soft tissue and bone tumors, the 2020 version, classifies rhabdos into four main subtypes. The top two, embryonal and alveolar, are the ones that most of us are familiar with, and the spindle cell sclerosing and pleomorphic rhabdomyosarcoma are probably less familiar for the pathologists. In recent years, molecular discoveries, especially increasing use of sequencing, have greatly improved our understanding of pathogenesis and genetic classification of rhabdomyosarcomas. Currently, integrative morphologic and molecular approach for diagnosis and subclassification of rhabdomyosarcoma is being encouraged. However, the emphasis of this talk is being practical. Sometimes we don't have access to molecular methods. So the emphasis is first being familiar with the subtypes, and second, being familiar with morphologic clues that could suggest such subtypes in absence of molecular tools. The importance of it is that molecular classification imports prognostically relevant information that may be useful in risk-adapted therapy. So with that, we're going to review the most current agreement on classification and molecular subtypes. Top of the list, embryonal rhabdomyosarcoma. It's in fact the most common subtype of rhabdomyosarcomas. It occurs in young patients with relatively favorable outcome. It's being most prevalent within the head and neck region, followed by genitourinary tract. In GU tract, embryonal most frequently arises in vagina and urinary tract of infants. The ones that occur in uterine cervix and corpus are uncommon and are usually associated with a later age of onset. All rhabdomyosarcomas have poor prognosis, but the overall survival of embryonal has significantly improved in recent years. Morphologically, they're characterized by immature appearing spindle to ovoid cells set in a variably myxoid stroma. The cells may form vague short fascicles, and the tumors can have alternating areas of cellular and myxoid variability with variable level of atypia. The more solid and densely cellular areas can be difficult and challenging to diagnosis, especially their distinction with solid variant of alveolar rhabdomyosarcoma, which we're going to discuss shortly, can be challenging. A quick word on botryoid rhabdomyosarcoma. It's a subtype of embryonal rhabdomyosarcoma, but it's really an anatomic variant of it. It occurs in GU tract, a hollow viscera, mucosal line surfaces. It has a polypoid growth pattern and is characterized by condensation of neoplastic cells underneath the mucosa, the so-called cambium layer. Here's a representation of a botryoid embryonal rhabdomyosarcoma. We have the epithelial surface on top, and we have the condensation of tumor cells underneath the epithelial surface. So that's botryoid ERMS. Another important concept in embryonal rhabdomyosarcoma is the concept of anaplasia. It's really built on criteria defined for Wilms tumor, atypical cells with enlarged hyperchromatic nuclei 3 times larger than the background neoplastic cells. It could be focal or diffuse, and it's an important prognostic factor, and currently the synoptics and the staging take that into account. This is an example of a paratesticular tumor, as evident by the tubules on this side, which shows focal anaplasia characterized by just large, very hyperchromatic cells. As discussed, it could be focal or it could be diffuse in different tumors. Another important thing in embryonal rhabdomyosarcoma, which in many ways applies to all rhabdomyosarcomas, is the effect of chemotherapy on the tumor morphology. Neoplastic cells show terminal differentiation after receiving chemotherapy. Morphologically, this is characterized by polygonal rhabdomyoblast with eccentrically placed nuclei and brightly eosinophilic cytoplasm, as evident in these photomicrographs. It could also be focal, as in these 2 cases, or be more diffuse and even impart a rhabdomyoma look, a benign tumor. But it's important to have this in mind, that the morphology changes after chemotherapy. Now, genetics of embryonal rhabdomyosarcoma, unlike alveolar, there hasn't been a distinct signature, a genetic rearrangement for embryonal. There are mutations, RASopathy, RAS, NRAS, KRAS, HRAS mutations, loss of allelic heterozygosity affecting loci on 11p, alternations in parental imprinting and hypermethylation, gains and losses. And while a majority of embryonal rhabdos are sporadic, some are syndromic, including the ones that are associated with Li-Fraumeni, associated with neurofibromatosis 1, and the ones that are associated with Dicer syndrome. So a subset of embryonal, interestingly, show Dicer 1 mutation. Those ones are reported in GU tract and uterus, but those could be both sporadic and syndromic. And there's currently a debate whether or not this Dicer mutated ones, whether sporadic or syndromic, should be characterized as a separate category. Now, moving on to alveolar rhabdomyosarcoma, it occurs in adolescents and young adults, so not in infants. It commonly arises in deep soft tissue of extremities in axial locations. Another common location is paranasal sinuses in parameninges, so head and neck areas. And in comparison to relatively favorable prognosis of embryonal, alveolar rhabdo has an aggressive course. It gives extensive metastasis, and it even has potential for leukemic spread. Some of you that do bone and soft tissue or had worked with diagnosis of alveolar rhabdomyosarcoma are familiar that usually these patients get bone marrow biopsies for involvement of bone marrow as well. Morphologically, it's characterized by a uniform proliferation of primitive appearing, undifferentiated, small round cells. These cells, as the name implies, are set in an alveolar architecture separated by thin, irregular fibrous septa. The cells are discohesive and can have a bit of a clinging look. This is a closer look at the tumor cells. They could be coming to differential of lymphomas, small cell carcinomas, and even germ cells. But this kind of eccentric nuclei and this plasmacytic look is characteristic for alveolar sarcoma. The tumor can have a more diffuse growth pattern in the solid variant, forming solid diffuse sheets. The solid variant of alveolar rhabdo has been officially recognized since 1992. The distinction between this subtype and dense areas of embryonal can be challenging, if not impossible, especially on limited biopsies, and we have to resort to molecular methods. Morphologically, this is an example of a solid variant of alveolar rhabdo. It's composed of same cells, essentially primitive appearing, small round cells, but there is no hint of alveolar architecture. It's a solid growth of the tumor. Immunostains are very helpful. Desmin is the kind of preliminary to see if there's any muscle differentiation, followed by myogenic and MyoD1. One practical point in diagnosis of alveolar rhabdo is that unlike other rhabdos, they have a strong and diffuse expression of myogenic in comparison to MyoD1. In other subtypes of rhabdomyosarcoma, MyoD1 expression is stronger than myogenic. So that would be a morphologic clue. Genetically, there are recurrent translocations identified in 80% of alveolar rhabdos. Those are PAX3 and PAX7 with FOXO gene, 75% with PAX3 and 25% with PAX7. There's a remaining 20% that are fusion negative, and the diagnosis of those can be challenging. There are some rare reports of other fusions, including PAX3 and COA1, PAX3 with NCOA2, FOXO4, FGFR1, but there's currently debate whether or not these are actually alveolar rhabdos. So for practical purposes, the top two with PAX3 and PAX7 are the ones that we're looking for. It's been shown that the prognosis of the fusion negative ones and the ones that have fusion with PAX7 are akin to prognosis of embryonal rhabdo, and they show a better prognosis. Now getting to spindle cell sclerosing rhabdomyosarcoma variant. To give a historical background, it was first described in 1992, and in its initial description, it was thought to be a subtype of embryonal. It's more common in paratesticular and head and neck region, with predilection for male patients with favorable outcome in pediatric population. A little later in 1998, Rubin and colleague described first two cases of spindle cell rhabdo in adult population. And in 2000, Menzel and colleague reported 3 cases that occurred in adults and had a distinctively hyalinized and sclerosing intercellular matrix. This was further confirmed by upcoming work by Fulp and colleagues. And similar sclerosing rhabdo has been described in pediatric population. So currently, these two terms, spindle and sclerosing, this is part of the same entity of a spectrum of tumors. We now know that it occurs in both pediatric and adult population. Now it's a standalone entity. And in contrast to favorable outcome in pediatric patients, spindle rhabdomyosarcomas in adult population follow a more aggressive clinical course. This is an example of a spindle cell variant of rhabdomyosarcoma. It's characterized by short spindle cells arranged in variably sized intersecting fascicles with vague whirling. There is very focal, if any, rhabdomyoblastic differentiation. The sclerosing variant, as the name implies, has a more sclerotic and collagenous background. And usually tumors show a combination of both a sclerosing and spindle morphology. So it's not a pure tumor as such. Immunostains are very helpful. Similarly, they're positive for desmin, MyoD1, and myogenin. I would like to point out, and it doesn't have to be all three of them, if there is any expression of MyoD1 or myogenin, there is rhabdomyoblastic differentiation, and it's worth working up for diagnosis of rhabdomyosarcoma. Usually the diagnosis is relatively straightforward and does not require molecular workup. However, genetically, the molecular findings point to distinct genetic subgroups. There is significant heterogeneity, even though the morphology is relatively uniform. The importance of it is that the clinical behavior varies in addition to age and location with underlying molecular alterations. So far, 4 subgroups have been defined for spindle cell sclerosing rhabdomyosarcoma, the group with MyoD1 mutation, a group with VGLL2 fusion, group with NCOA2 fusion, and the most recently described group is the one with TFCP2 fusion. So going over these 4 groups briefly, as their behavior is different. The ones with MyoD1 mutation is relatively recent, described in 2013. It occurs in a wide age range, but it's an aggressive tumor, both in pediatric patients and in adult patients. It seems to be a tumor of head and neck regions, followed by extremity and trunk. It could have homozygous or heterozygous mutations on chromosome 11. In addition, some mutations on PIK3, NRAS, and HRAS has been reported as well. It's characteristic to show diffuse and a strong expression of MyoD1 with focal or patchy expression of myogenin. So the ones with MyoD1 mutations, adult and pediatric population, and follow an aggressive course. The ones with VGLL2 rearrangement, interestingly, almost exclusively occur in soft tissue and infants and in congenital settings. These are rare tumors, but based on the 2 larger series so far, they appear to have intermediate malignancy with favorable outcome. The ones that have been reported so far were all located in soft tissue in extensive metastasis, has not been reported. The fusion partners include NCOA2 and CITED2 so far. These are the reported ones. Similar to VGLL2 ones, the ones with NCOA2 almost exclusively occur in infants and congenital settings. They also have intermediate course and favorable outcome. One recently reported exception is NCOA2 rearranged intraosseous rhabdomyosarcomas in adult patients, which follow an aggressive course. Those are the tumors that showed fusion with MACE, NCOA2. Interestingly, VGLL2 and NCOA2 can fuse together. So there's this thought that these 2 fusion tumors are actually part of the same spectrum. Other reported partners include SRF and TAD1. So the ones with NCOA2 do well, and they're in congenital settings. The rhabdomyosarcomas with TFCP2 rearrangements, these are the most recently described molecular category. They appear to have propensity for female patients, osseous locations in head and neck, and TFCP2 could be fused to EWSR1 or FOS. This has been first reported by this French sarcoma group in a workup of a large cohort of small round blue cell tumors, and later confirmed by our group in Mayo Clinic. Morphologically, they show a combination of spindle and epithelioid morphology. These show a diffuse expression of keratin and ALK along with myogenic markers. So a diagnosis of a poorly differentiated carcinoma is strongly considered in differential of these rhabdomyosarcomas. Here's a case, an example of such rhabdomyosarcomas, just to highlight the clinical application. This was a 62-year-old woman that presented with lower back pain. Imaging showed a heterogeneous and destructive mass in body of L5, almost entirely replacing the bone. Multiple biopsies were performed, and they all showed keratin expression. However, in imaging, there was no indication that this is metastasis of another site of primary. On the biopsy, the marrow is completely replaced. There are cords of epithelioid cells with keratin expression. So it's a middle-aged woman, bone lesion that expresses keratin. It's carcinoma until proven otherwise. Given the symptoms, neurologic symptoms of the patient, she underwent corpectomy, which shows a better morphology of the tumor, solid sheets of tumor cells, cording architecture, epithelioid morphology, and distinct cell borders in a somewhat of a collagenous background. Similar to the biopsy, this tumor showed a strong and diffuse expression of keratin, but interestingly, in addition to keratin, it showed expression of MyoD1 while being negative for myogenin and desmin. Given the confusing immunohistochemistry, this was sent for molecular analysis, RNA sequencing, and it came back with rhabdomyosarcoma with TFCP2, AWSR1 rearrangement. So the diagnosis for this patient completely changed from carcinoma to sarcoma, and she received the sarcoma chemotherapy instead of a carcinoma one. Just to highlight intraosseous rhabdomyosarcomas, we covered two of them so far, the spindle ones. At least two molecular subtypes have been reported. Ones with NCOA2 rearrangements that we discussed, they follow an aggressive course and it's in adult population. And then TFCP2 ones, we also discussed that with propensity for head and neck of female patients, and they both follow an aggressive course. Okay. Now, even after including all of those subtypes, we need to stay tuned as there are new subtypes being reported, new molecular subtypes being reported in the spindle cell and a sclerosing subtype. This particular one with EWSR1, UBP1, it was a novel fusion. Similarly, this tumor expressed keratin. The patient even received carcinoma chemotherapy, and later it turned out that the more fitting diagnosis is rhabdomyosarcoma. There are more recent reports as of May of 22 with NCOA3 fusions. We already discussed NCOA2. They appear to have a fibrosarcoma-like morphology and again, aggressive course. But interestingly, the latest one, which is VGLL3 fusion, in contrast to VGLL2 fusion, was shown to have a more indolent clinical course, but similarly, a predilection for head and neck. It's worth going over this subtype as it has a different behavior from other spindle rhabdomyosarcomas. The partner ones that are reported so far are these three. As discussed, it has a likely indolent behavior, and I say likely because it's a small series, but highlights the importance of distinguishing this subtype from other aggressive ones, and maybe treating these patients with the same chemo as the other aggressive subtypes could be considered over treatment. Okay. The last subtype that we're going to cover is pleomorphic rhabdomyosarcoma. It was first described in 1946. This is the most common rhabdomyosarcoma in adult and elderly. It has a very poor prognosis. Even though it's the most common one, in adult and elderly, the incidence overall is not that high. It's 2 to 5% of adult soft tissue sarcomas, usually rapidly growing regressive masses, often located in deep soft tissue of the extremities, especially lower extremity, although there are reports of these happening in trunk and retroperitoneum. Morphologically, they resemble a high-grade pleomorphic sarcoma, essentially, with highly atypical cells, some showing polygonal, spindle, and round morphology with eccentric nuclei, brightly eosinophilic, granular cytoplasm. With a closer look, they can have somewhat of a gangliocytic look to them. The diagnosis is really hinges on the immunohistochemistry. Usually there's patchy expression of desmin, and the expression of either myogenin or MyoD1 is a requirement for this diagnosis. However, it could be very, very focal. We could be talking about a handful of cells expressing either myogenin or MyoD1. Genetically, no recurrent structural changes have been identified in pleomorphic rhabdomyosarcomas. It has the same genetic profile of high-grade undifferentiated pleomorphic sarcoma. It's very complex, a lot of gains and losses in amplification. So there is nothing that can really pinpoint this diagnosis other than morphology and immunohistochemistry. With that, I would like to conclude this talk. Just an emphasis that currently we have 4 subtypes of rhabdomyosarcoma recognized: embryonal, alveolar, spindle cell / sclerosing, and pleomorphic rhabdomyosarcoma. We discussed that age, location, and subtype of the tumor affects the prognosis of the patients. We discussed the supportive immunohistochemistry, as well as pitfalls such as aberrant expression of keratin, especially in the spindle variant, and overexpression of ALK, similarly in the spindle variant. We also discussed molecular subtype and how they affect the outcome of the patient and biology and the behavior of the tumor. It's been encouraged to submit these tumors for molecular subtyping, as it could stratify patients to low risk, intermediate risk, or high risk groups. But in the absence of molecular tools, morphology and immunohistochemistry should get us close to that subtype. Thank you so much for your attention. And with that, I'd be happy to take any questions. Thank you.
Thank you so much, Dr. Dashti, for this very informative talk on rhabdomyosarcomas. We have a few questions from our audience here. So the first question is, can we differentiate spindle cell rhabdomyosarcoma from fibrosarcoma or monophasic synovial sarcoma morphologically?
Morphologically, with the help of immunostains, I would say yes. That's a great question. These are in each other's differential, especially since synovial sarcoma could similarly show expression of keratin. I would say that if you have expression of myogenic marker, including myogenic markers, including myogenin and MyoD1, I would err more towards the rhabdomyosarcoma morphology. And if there is absence of those, there's keratin and EMA expression, I would err towards synovial sarcoma. And if all 3 of these are absent, I would probably move towards fibrosarcoma. So the diagnosis of fibrosarcoma is mainly diagnosis of exclusion. So after everything else is ruled out, then we're kind of left with this diagnosis of fibrosarcoma.
Right. Thank you, Dr. Dashti. So here is another question from one of the viewers. The question is about the utility of immunostains. So like for rhabdomyosarcoma, among the different muscle markers, which are the markers that you rely more for diagnosis?
For diagnosis,
Thank you.
I usually do, thanks for the question. I usually do desmin, myogenic, MyoD1, all three. If there is not access to all three of them, I recommend myogenic, MyoD1, and it's usually prudent to do them both because some tumors, as we discussed, can have very patchy myogenic expression while being very strong for MyoD1. Most of them are actually like that. Or in this new molecular subtypes we have complete absence of either myogenic or MyoD1. So I would recommend doing those two together. If there is no access to both of them, one of them at least be included in the workup.
Right. Thank you again. So the next question is about, so let me read it for you. How to differentiate pleomorphic rhabdomyosarcoma from leiomyosarcoma with rhabdoid differentiation?
That's an excellent question. It could be difficult. And, for practical purposes, it may not actually make much of a difference in the treatment that the patient receives. And if you go through a large series of pleomorphic rhabdomyosarcoma, you could see that some pathologists may call some pleomorphic rhabdomyosarcoma and some may call, poorly differentiated leiomyosarcoma with rhabdomyoblastic differentiation. So anything with rhabdomyoblastic differentiation could actually fall under the umbrella of looking like pleomorphic rhabdomyosarcoma. For practical purposes, I think you can choose whichever one is closer. I think if you have a more strong expression of desmin, caldesmin, and SMA, I would err on the side of leiomyosarcoma. If you have a stronger expression of myogenic, MyoD1, I would err on the side of pleomorphic rhabdomyosarcoma. So I would use those to differentiate between the two.
Right. Thank you again. So there is a question about the utility of molecular markers. The question is that how useful is molecular markers for differentiating rhabdomyosarcoma from other sarcoma subtypes?
In general, I mean, that's more of a philosophical question. That's an excellent question. That's a question that we struggle with every day. I think the application of molecular in general could be two ways. Sometimes it's for diagnostic purposes, sometimes it's for prognostic purposes, and sometimes, like the third way, is part of a research or a grant or some sort of an investigative work outside of patient care. I believe for the most part, the diagnosis of rhabdomyosarcoma could be straightforward with morphology, clinical, and a good immunohistochemistry. The difficulty is where either none of those exist, or we have kind of a confusing immunohistochemical pattern, especially the ones that express keratin. In comparison with other ones, I think that we don't need molecular for diagnosis, but we do need molecular for prognosis of rhabdomyosarcoma if there is access. For example, alveolar rhabdomyosarcoma, even though the diagnosis may not be very difficult as the morphology is very distinctive, but knowing that these patients are in PAX7 or PAX3 or a fusion negative group really affects their outcome, and that's what clinicians have to deal with. So that's where the application of molecular comes in rhabdomyosarcomas, in my view. It's more in prognosis than in diagnosis of these cases. Right. I hope that clarified kind of approach that I have to these cases.
There is a related question about molecular markers in soft tissue tumors in general. So the question is that in most of the places, molecular markers are not available to be done in majority of the countries like where pathology is practiced. So, I mean, the question is, in the absence of molecular markers, so what is the best approach to classify different types of sarcomas? Like nowadays, that many of the sarcomas are, defined by molecular markers.
That's a very difficult and important question. And even in, say, places that there is access to molecular, at the end of the day, someone has to pay for that bill of molecular workup, and sometimes insurance doesn't accept that, clinicians don't like that. So it's a challenging aspect of pathology altogether, especially in soft tissue, as the person who asked the question mentioned. We are really moving towards tumors being defined by their molecular underlying molecular event. I do think, well, the good news at least is that treatment for a lot of these depends on the grade of the tumor, and it's not necessarily subtype related. Rhabdomyosarcoma is an exception. So I feel like even if there is no molecular tools available, with limited immunostains and good sampling, as long as we can get it to this is a low-grade sarcoma or this is a high-grade sarcoma, that would be very beneficial for clinicians. It may not be very satisfying for us in terms of really nailing the diagnosis, but sometimes that's all the clinicians need to know how to treat the patient. So it's not really subtype dependent. That's one way of getting around it and being practical.
Right. So though this question is not exactly related to rhabdomyosarcoma, so I will read it for you. That what is your experience about using immunohistochemistry for translocation X18 in synovial sarcoma?
Oh, that's an interesting one. It's actually been very good. I'm very impressed with how it works. We are getting some other immunostains that are surrogate or markers for molecular changes. I think maybe one of the first examples was beta-catenin, which is, I don't find beta-catenin very easy to read. But actually for synovial sarcoma, it works very well. And many times you don't need a molecular confirmation for such cases. It's been a very positive one.
Thank you. I think this should be useful for our audience. So here is a question from another of our listeners. So this is a long one. I will read out to you. So if you have a round cell tumor in the pleura with strong Dasmin and myogenin positivity in a 50-year-old, how would you confidently be able to sign it out as alveolar rhabdo? What else do you recommend? Mm-hmm. Given the patient has no previous history of rhabdo and no tumor elsewhere, and that other round cell tumors are excluded by immunos. So I hope you got the question.
I got that. Okay, so we have a 50-year-old with a solitary tumor in pleura. Question is whether or not we can make the diagnosis of alveolar rhabdomyosarcoma in there. It's positive for Myogenic and MyoD1. It's a relatively unusual location for alveolar rhabdo, I have to add. I think this patient, given the age, another important diagnosis would be carcinosarcoma with rhabdomyoblastic differentiation or even MPNST. I know that it was mentioned that other diagnoses had been excluded, but I would strongly consider those in that age group. So I would add keratin, Soxten, S100, do a workup for those. And I think sending it, if there's access to molecular, having confirmation of a FOXO rearrangement would make a diagnosis clear that this is alveolar rhabdomyosarcoma. But given the age, I wonder if the diagnosis is something else with rhabdomyoblastic differentiation.
So that means that the age will also be an important factor in this particular patient.
Yes, exactly. Pleura, I mean, if it were in head and neck or in sinus area, in parameninges, but in pleura, it would be a bit of an unusual location for rhabdomyosarcoma, for alveolar rhabdo.
Right. So there is another question. Let me read it for you. Alveolar rhabdomyosarcoma has the worst prognosis. Is that correct? Can we expect alveolar rhabdomyosarcoma in children?
Yes. Okay. So first question, it has poor prognosis. Is it worse? It's comparable to some subvariants of a spindle, a sclerosing rhabdo. So those two, alveolar and a spindle, they do very poorly. Pleomorphic does very poorly. The only one that has a more favorable outcome is embryonal, and some subtypes of a spindle, the ones that have VGLL2, the one that have NCOA2, they do better and they're in congenital settings. As for the question whether or not alveolar could happen in children, yes, but usually adolescents versus really young age that happens in embryonal. So embryonal, earlier congenital, infant; in alveolar, more adolescent, young adult, and middle-aged adults.
Right. I think these are the questions I saw online, and I don't see if any more questions so far. And I'm looking at both Facebook and YouTube chat windows. So with that, I would like to thank you again, Dr. Dashti, for this excellent talk on rhabdomyosarcoma and its variants, and you have taken time to answer so many questions from our viewers. And you would be happy to know that there were around 100 viewers who watched the talk from different parts of the world. And thanks to all our viewers. And if you like our lectures, so please don't forget to subscribe our YouTube channel, that is Pathcast, and follow the Facebook page, that's also Pathcast. And we also have a website where all the lectures are organized, so that is pathologycast.com. And our next lecture is coming up, so that would be on GI pathology, and we will have a talk on infectious GI pathology, and the title of the talk is Infectious Insanity in the Digestive System, and our speaker is Raul Gonzalez from Emory University, and that would be on January 31st, 2023. It's the same time. It is 9 a.m. Pacific time and 12 p.m. Eastern time zone in US. So hope to see you then. And thank you again, Dr. Dashti. And stay tuned for the next lectures that are coming up in the bone and soft tissue series.
Yes,
and we'll keep you all posted. Thank you again, Dr.
Thank
Dashti.
you, everyone. Have a good day.
Bye.